Hello and welcome to Everyday Medicine. I'm Dr. Luke and I'd like to thank you all for joining me on this podcast series where we share conversations with colleagues, exploring their special interests in medicine and bringing insights, ideas and advice which I hope will be applicable for our medical practices. In this podcast, we're talking with an expert ENT surgeon on Globus. For Australian audiences, listening does give eligibility for your CPD, so log in and add this as an activity. You may also consider journaling, reflection, and adding to the review and performance section in your CPD. Well, Globus is a persistent or intermittent, non-painful sensation of a lump or foreign body in the throat. It's a well-defined clinical symptom that is usually long-lasting, difficult to treat, and has a tendency to recur. This symptom frequently improves with eating and is generally unaccompanied by dysphagia or odynophagia. It's a common condition that accounts for approximately 4% of new referrals to ear, nose and throat clinics, and it's reported by up to 46% of apparently healthy individuals with a peak incidence in middle age. The condition is equally prevalent in men and women, although the latter are more likely to seek healthcare for this symptom. Hippocrates first noted Globus pharyngeus approximately 2,500 years ago. In 1707, Purcell was the first to accurately describe the condition. He believed the Globus resulted from pressure on the thyroid cartilage due to contraction of the strap muscles of the neck. In the past, Globus was described as Globus hystericus because of its frequent association with menopause or psychogenic factors. However, Malcomson coined the more accurate term Globus pharyngeus in 1968 after discovering that most patients experiencing Globus did not have a hysterical personality. The etiology of Globus is still unknown but appears to be multifactorial. Although data are limited, recent studies have focused on gastroesophageal reflux disease, abnormalities of the upper esophageal sphincter, psychological and psychiatric disorders, and stress as major factors contributing to the Globus sensation. The variety of potential etiologies has made it difficult to establish standard investigation, and treatment strategies for affected patients and an open mind in terms of presenting causes needs to be maintained. Well, Dr. Andrew Martin is a practicing ENT surgeon in the southeastern suburbs of Melbourne and northern Tasmania. He completed his MBBS at the University of Queensland in 2008 after a Bachelor of Pharmacy Sciences with honours from Monash University in 2003. He then completed his fellowship with the Royal College of Surgeons in otolaryngology and head and neck surgery in New Zealand in 2021 and completed an advanced fellowship in head and neck surgery at the Royal Melbourne Hospital in 2022. He has special interests in nasal obstruction, obstructive sleep apnea, ear and balance problems, chronic sinus disease amid facial pain, paediatric ENT, as well as swallow, voice and throat disorders. Andrew is also a busy family man with 2 young daughters and enjoys hunting and fishing. It was a great privilege to have this conversation with him, exploring Globus symptoms in more detail. So please welcome Andrew to the podcast. Andrew, welcome back. We're now going to talk about, it's a little bit more of a crossover with gastroenterology, Globus, chronic cough. This is, it's an old chestnut, isn't it? We see this quite a lot in clinical practice, and often we're referring patients to you and vice versa. Take us through your approach to these problems. What's your, how do you sort of advance the diagnosis and management of these patients?
Yeah, no, that's good. I think sometimes we are too simplistic with Globus. Some people will call it laryngeal hypersensitivity, and I don't think it's even clear whether it's the larynx that has got anything to do with Globus. And I think certainly in training, I found it incredibly frustrating because you'd see people come and it was always reflux, and you'd put Gaviscon, and you put everyone on Gaviscon. And because we tended to follow everyone up, you'd see people come back 3 months later, oh, that made no difference at all, doctor, but thanks for trying, But about 30% of the time, oh, that Gaviscon worked like a charm, I don't have that Globus sensation anymore. It's not quite how they would say it, of course, but and so it's very interesting because it's, again, an area like midfacial pain where the evidence is generally quite weak, and we know a bit about effective treatments, but it's not even a condition in which we entirely understand the pathophysiology. However, that being said, there was a large study done, experimental study, where they applied I don't even remember how they did this, but in fact, they were doing upper esophageal pH manometry, I think, and they applied acid to the distal esophagus. I don't even know how you would do that. Some pH which wasn't caustic, I suppose, and they found that they were able to replicate globus in a large proportion of cases by acid exposure to the distal esophagus. So when acid came up around the GOJ, people developed a globus sensation at the upper esophageal sphincter. And simultaneously with that, they measured an increased contractile pressure in the upper esophageal sphincter. I might divert here and ask you actually what you think about this and whether that sort of rings true or whether
I think it does ring true. And I think up to 60% do have abnormal pH studies. So I think there's a group of quite a large group, perhaps not all, but a large group that have this sort of sensation of that tightness, that fullness in the top of the throat, maybe sometimes with a little bit of high dysphagia. And I agree, it's related to a little bit of hypertension that's developing in that upper esophageal sphincter region, and one could maybe argue it's there, it develops biologically to protect against reflux, particularly nocturnal reflux, to prevent aspiration, and that tightness is something that patients become very aware of. So our normal approach is then try and identify the reflux, and that may be a gastroscopy. It may actually mean doing a pH probe study, although that's often a little difficult to organise in clinical practice. The patients don't always thank you for doing that test. And then to consider doing an esophageal dilation to stretch that upper esophageal sphincter up. And it's not universally successful, but it's certainly successful in a significant portion. Like a majority of patients really do feel relief from that. And I'm also always concerned there may be some other pathology going on. So
I find that's very fascinating because clearly reflux treatment in its own self is not always adequate, and it seems that with either PPIs, Gaviscon, or a combination of the both, there's still a large proportion of people for whom it makes not a diddly squat of difference.
I think you have to consider dilating as well as then, yes, provide.
I think that's something I haven't really woven into my practice, but now that you've mentioned it, it makes perfect sense. And essentially you guys are the best people to do that. And now it's also interesting that I think there's a proportion where it definitely is psychological. If you've ever had a very upsetting thing happen in your life, someone died or something like that, you get that lump in your throat, that tightness. And I think that that might still be the same end result. There might still be cricopharyngeal muscular contraction going on. But it might be from a different source, i.e. emotional. And it's interesting that a Chinese study looked at, and they did an RCT on SSRIs for globus, and they found it was highly effective. Now, I wonder, because it's a difficult study to prove much because it's a subjective symptom. And in fact, that's why we know so little about globus, because it's a subjective symptom.
Yes.
But there's not a measurable outcome beyond a patient-related outcome measure. But the fact that it was so swimmingly successful makes me wonder: were they treating just the emotional stress that people feel from globus, or is there some other thing we're not quite aware of in how an SSRI works?
Well, maybe releasing that degree of tension, emotional tension.
But I always, when I write back to the referring doctor, I always include that as an option that could be considered if the patient fails to.
I think patients need a good explanation for why you're giving it to, because they sometimes don't always accept that sort of medication with great happiness, do they? And often it's accepted with a degree of suspicion, I find.
I think 90% of them will say, no, I don't want that, doctor. They don't want, because they know that the side effects and they don't want those,
Yeah, I think they're suspicious of what you think is going on as well. They think, actually, they're just.
I think you're right there. I think they're
depressed, or it's all psychosomatic. Sometimes we use baclofen as well as an alternative drug.
Okay. What dose do you use, Luke, out of interest?
At least 20 milligrams a day, usually a spec dose, and increasing it.
Do you have to sort of up dose as you start?
I normally start off at 10 milligrams twice daily, and then I'll increase the dose a a little above that, maybe up to twice that, depending on the response the patient is reporting. But I would have to say that I find esophageal dilation the most effective by a long shot. And when there is reflux, of course, associated with effective acid suppression therapy, and also make sure there isn't thyroid disease or some other pathology going on.
Well, look, so it confirms to me, Luke, that it really does seem to strongly indicate, put it that way, that the upper esophageal sphincter seems to be primarily implicated in globus, which would explain why upper esophageal dilatation is effective.
Yes.
The other thing which some of my colleagues do, which I really don't do, and I don't think there's any value in, is assessing for thyroid nodules. I think if you, and this is my controversial statement for the night, I think if you can't palpate a goiter, this is not due to a thyroid nodule.
No, you have to have a very substantial goiter, I think, for it to be an issue. And
I think so too, yeah.
Something very substantial.
And I think often we know from thyroid treatment that if you lay an ultrasound on just about anyone, you've got a 50% chance of a nodule, and you've got about a 5% chance of detecting a papillary thyroid cancer, most of which would have sat there quite happily for the rest of that person's life without causing any trouble.
I would agree. I think a nodule demonstrated like that is probably just coincidental. It's an innocent.
Yeah. Yeah, and I'm not saying if you find a nodule then ignore it, because you do work it up the way you normally do, based on its TIRADS and whether you FNA it based on your TIRADS, etc. However, we probably do too many thyroids is the bottom line,
yes.
And I don't honestly think that it's got any connection in the vast majority of cases to a globus sensation in the throat.
Well, what about your approach to cough? Tell us about an ENT approach to the management of cough.
Yeah, so cough I like to think about as it's one of those great things where it's going to be one of several different things. It's either going to be sinonasal, respiratory, upper GI, drug-related, or neurogenic.
Yes.
And once you include those things, unless tell me if I've missed something glaringly obvious, I really think you've ticked off most of the boxes. Now, in terms of going back to the start, sinonasal, it's really only the cause when you have other associated symptoms of sinusitis. Often when we put a scope down in the clinic, you'll see thick mucopus draining down into the postnasal space from the sinuses. You're like, okay, that's the cause of your cough, all right, until proven otherwise. I had a chap to see me in the clinic and he had chronic sinus inflammation on his CT, but when I stuck a scope in his nose, it looked totally pristine, and he had a chronic cough that had been going on for about 20 years. And I asked about other sinus symptoms. He had none, and it all started after a coryzal illness 20 years earlier. So I said, you know what, you actually don't need sinus surgery. He was relieved to hear that, of course. You need gabapentin. And so I put him on gabapentin, and he came back to see me, said no more cough. It had been going for 20 years, switched off the cough. So clearly it was a neurogenic cough, and he just coincidentally had sinus disease, but it was clinically silent sinus disease.
Yes.
So I know I'm diverging into one of the areas, but I think you've got to look clinically at what's going on in that person, not just radiologically. So sinonasal, we've already alluded to neurogenic cough. Respiratory, now obviously that's beyond my expertise, but I always ask them about asthma, see if they've had previous pulmonary function tests. Often in children, of course, chronic nocturnal cough is due to asthma, but you also got to think about in young kids, big adenoids, because in children, adenoids cause chronic sinus disease, and the treatment is just simple adenoidectomy. And often when you do take out their adenoids, there'll be a thick coating of mucopus on them in those sort of children. And then I think GI, but really you're the man here to explain to us about that, I think.
Well, that's a nice. I like your approach to that actually very much, Andrew. That's very clearly discussed. And I actually haven't used gabapentin, but I have seen patients. Thank you for discussing that and raising that, because I have seen patients who have been referred because there's this comment, we think the cough is due to reflux. And you'll ask the patient, do you have any reflux? I don't have any reflux. Don't describe this at all. And they've had a gastroscopy. Now, they may have a gastroscopy and they can certainly still have non-erosive reflux disease. We know actually there's a majority of patients that have non-erosive reflux disease, but they're not describing any symptoms. If there are no symptoms and there's nothing to find, and you might biopsy the esophagus as well, perhaps we've done a pH probe study, that would be definitive if you've done a pH probe study. But if you haven't found any real sign of reflux, then it's very improbable, therefore, that it's going to be reflux. Often those patients are put on PPIs, single dose, double dose, often with the prokinetic. Nothing ever changes. So I think that we can say, well, it's not due to reflux. It's got due to something else. So maybe gabapentin or something should be tried. It's a very interesting consideration. I think when we see someone who's got very significant reflux and there's esophagitis and there's a hiatal hernia, and you can see visually refluxate coming up into the esophageal body during a gastroscopy when they're lying flat and in the left-sided position for the examination, I can completely understand this patient's going to get nocturnal reflux and have a cough from that. And those patients need aggressive therapy and maybe even a fund application. The problem is the group of patients in whom you don't see anything. That's sort of arguing it's non-erosive reflux disease, and you put them on a PPI as you're trialling things, and they may be a little bit better, but not a lot better. And I think those patients, perhaps it's going to be the neurogenic etiology, but those patients need a pH probe study really to sort this out. Are they really true?
I think I remember, Luke, at that other talk that you and I both presented at, your discussion, and it seems like pH probe studies are difficult. So ultimately, we go on clinical grounds on the whole, and just an empiric treatment on the whole.
Yes.
When would you consider? When would you consider referring someone for, let's say, a fundoplication to a GI surgeon or a hiatus hernia repair?
Well, that's the patient who's got symptoms that are responsive to PPI therapy. The PPIs may have to be used in quite high doses.
But it's actually working for them.
It's actually working for them, yeah. Right. And so you've got proof that it's actually their problem, and they might be of an age too where they really don't want to commit to long-term treatment, or they may have had some respiratory issues that are very real. They may have developed an aspiration event. They may have bronchiectasis from chronic reflux events, like respiration at night. And those are the sort of patients in whom we're considering the fundoplication. So it's based on definitely a response, definitely proof, and patients' desire for an alternative to medical therapy.
Yeah. I see what you're saying.
We have got an interesting crossover because I think often I see patients who are referred from an ENT source, and it's we've put them on a PPI already, but they've got the cough and there's a little bit of redness in the back of the throat seen during an ENT exam. We think it's reflux. I don't think it's that long.
Yeah, I always find that.
I don't actually agree with it. I sort of think, that's a bit of a handball. I don't think
it's most definitely a professional handball. You can 100% guarantee that. But it's also interesting that the sort of concept of redness at the back of the throat, I find that a little bit
non-specific.
A little bit non-specific and a bit nebulous, to be honest, because it's all a bit red when you look down there. The mucosa, the healthy mucosa almost looks red.
Yes. I was at a GI conference at the Mayo Clinic, and they were talking about this, and they weren't particularly impressed by those discussions. But we have a degree of professional courtesy, so you don't want to really call people out necessarily on it. But I think it's probably overdiagnosed.
Well, and then what's your? While I've got you here, esophageal candida.
Yes.
Does that ever cause chronic irritation of the esophagus and therefore a chronic cough? Or?
I don't think that I could convincingly say that it does. Those patients either are not aware of it at all, or they have dysphagic symptoms when it becomes particularly heavily coated. And these patients are generally on puffers. Okay, they might be diabetic and they've had antibiotic therapy and so forth, but they're often on some steroid inhaler. And they'll have maybe a dysphonia and even a bit of irritation of the vocal cords from that puffer. Yeah. So, but I wouldn't argue that it's the candidiasis that's caused that. No.
No, because I occasionally see when I just do a flexi scope in clinic, what looks like candida in the tongue base, and it's always a very non-specific thing. I think it's I think it is associated with mouth breathing and dried mucosa, but
Yes.
again, that's a little bit speculative on my part. And sometimes there's a little bit of a blurred line between that sort of whitish, sloughy exudate and actual candida. And I think sometimes we misdiagnose candida just by looking at that sloughy, whitish stuff that you get from
cells, epithelial cells.
desquamated, macerated epithelium. Kind of looks whitish, and I feel like we overcall candida sometimes.
I agree. Andrew, you've taken us through a really interesting discussion across many broad things. I think it's been extremely helpful. And I think a lot of the tips you've provided, they've actually helped me just discussing this with you.
Oh, no, this has been very helpful for me too, just listening. Yeah.
I would like to ask you one last thing, Andrew, and that is like the best advice that's been given to you by, say, one of your mentors. Leave us with a little pearl.
Yeah, look, I think the best advice that I've been given is always listen to the patient first, let them do all the talking. Let them hog the conversation, and you'll pretty much figure out all the answers. These days, I do take over a little bit, when the patient's off waffling and tangential. But even when they're tangential, you're picking up little bits from the conversation. And when they're all over the place, you're still okay. I can fill in. I've already ticked off a few of my checklists. By the time you sort of start to direct them back onto a productive sort of conversation. The second thing I always what my mentors in training always told me, and really stuck in my mind, is never talk anyone into an operation. I always talk people out of surgery, and I want people to talk me into an operation because they're really convinced in their own mind that they need an operation. And like I was saying before, you can see some people that just have florid sinus disease, or they just tick the boxes. That person needs surgery, but they don't want it. And you always respect that patient's wishes, and you just say, look, come back and see me if you change your mind. But in the meantime, I'll still do my best to help you as best as I can. Take this particular thing.
That's very sage advice, Andrew. Look, thank you so much. It's a real privilege for me to have this discussion with you, and I wish you all the best in your clinical practice. Thank you for providing such great care to our patients, Andrew, and I wish you all the very best.
No, pleasure, and the pleasure is all mine, and thank you for your many insights in our conversation.
Thanks, Andrew. Thank you. I'd like to thank you all for staying with us during this conversation on Globus with the expert ENT surgeon, Andrew Martin. I really enjoyed the conversation with him, and I think I gained some new insights into how I may manage Globus as a gastroenterologist. I hope this has given you some food for thought also. During the podcast series, we will be covering a wide range of topics across many specialty interests. The discussions are not intended as specific medical advice for patients, but as general information only, and reflect the opinions of the guests interviewed. Requests for new topics to be reviewed and comments about the conversation you've listened to are welcomed and may be emailed to manager@gihealth.com.au.